Good afternoon, and thank you for joining us for the National Conference of State Legislatures Public Health Webinar Series. Our webinar today is titled Public Health Approaches to Children's Oral Health During COVID-19. My name is Eric Skinner, and I am a Policy Associate in NCSL's Health Program, and I'll be your moderator for today. Before I introduce our speakers, I want to review a few housekeeping items. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions in or answer any questions in the chat box on your screen. To begin building some comfortability with the chat function, I'm going to ask everyone to type in the name of the state from which you are calling in today. We will use the chat box for any questions during the Q&A after our speakers are finished presenting. I'd also like to briefly mention the resources. Above the presentation, you will see a couple tabs with one of them labeled Resources. Here you can find and download a PDF version of the PowerPoint presentation, as well as some other handouts. We have a lot of information to communicate today, and I suggest downloading the PowerPoint slides now in case you'd like to refer back to them. Another tab is labeled Speaker, where you can read the full bios of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is also being recorded and will be available on NCSL's website within a week. I would also like to thank the DentaQuest Partnership for Oral Health Advancement for their support of this webinar. So here's our agenda for today. We have a national overview that will be followed by two state speakers in our state section, and we'll end our time together with some Q&A. So we're here today to talk about how COVID-19 has affected children's oral health. We will take a look at how community oral health settings have been impacted and have adapted. These community settings include school screening programs, community health clinics, and networks of dental providers that play important roles in preventing oral disease in children and treating it quickly and effectively when it does occur. State legislators consider many bills and fund programs that address children's oral health. It is our goal today to explore state oral health program and policy options that state legislatures commonly address in the areas of workforce, teledentistry, and disease prevention. We will hear from two state dental directors to learn about how their public health agencies implement oral health programs and work with stakeholders on policy issues. Reminder that oral health
We apologize for the technical difficulties with the sound. I will go ahead and finish up introducing the agenda for today for Eric, as well as introduce our first speaker. So first we have Dr. Paul Glassman, who is the Associate Dean for Research and Community Engagement at the College of Dental Medicine at California North State University. He has a long career working with special populations in a variety of practice and community settings, and has served on many national panels, including the Institute of Medicine's, or IOM's, Committee on Oral Health Access to Services, which provided the report on improving access to oral health care for vulnerable and underserved populations. Dr. Glassman will provide a national overview and describe challenges of delivering care during a pandemic, and then we'll move into the state section of the webinar. Dr. Glassman, the floor is yours.
Great, thank you. Megan, can you verify that you're hearing me?
Yes, we can hear you.
All right, very good. Well, thank you. I appreciate the opportunity to be here and to talk about this very important topic. As you just heard, I'm going to try to paint a little bit of a picture of sort of the national trends in oral health that are related to reaching people that normally have a difficult time getting access to dental care, and towards the end, specific reference to how the pandemic is making that even more difficult, but some things that we can think about doing to mitigate that, and then sort of a look towards the future. So I'll start out with this slide, which is from Dr. Karen Smith, the former director of the Department of Public Health in California, just looking at the big trends in healthcare in general, that we're seeing an increasing focus on health versus healthcare. I hope the difference is obvious to everyone. No longer enough to provide late-stage repair, that we've really got to be thinking about addressing the social determinants of health and all the things that get people into having poor health, sort of upstream, as the public health term is often used. Recognizing the fact that we're dealing with a more complicated, older, more diverse population than ever before. And so all of that is leading to an increasing interest in the community as a level of focus. It's not just enough, okay, to say we're delivering good care for someone who happens to walk through the door of a dental office, but what's the health, particularly the oral health of the community? And then, of course, the value of big data and being able to measure value is helping us think differently about healthcare than we used to. So now just a couple minutes on oral health. This is some data from the American Dental Association's Health Policy Institute looking at who's getting dental care in our country. And the three lines is broken down by age group. The highest utilizers of care are children. This data is a little bit old. It's now a little over 50%, but it means about half the children in the country are not having even an annual dental visit, certainly not getting any kind of regular dental care. Even worse for seniors, and only about a third of working age adults having regular dental care. So we actually have a situation in the United States where the current dental care system is primarily serving the wealthiest and healthiest segments of the population. And the converse of that is most people with most of the dental disease are actually not engaged in the dental care system. Moving forward with trying to figure out what are we going to do about that, I'm proposing here to think about these three things in the Venn diagram as the steps, as the paths forward. One is about thinking about measurement and payment systems that are increasingly becoming focused on measuring health outcomes and providing incentives to do better with health outcomes. Delivery systems that are reaching people who are not being able to get normal dental care in a normal dental office. And then when you're with people, some new prevention and behavior science. So I'll just touch briefly on a couple of these and spend a little bit more time on delivery systems. But in terms of the measurement, we have a lot of groups in the oral health industry that are a little bit behind general health care, but are working very hard. The Dental Quality Alliance is a group that's facilitated by the American Dental Association, producing lots of measures for oral health reimbursement systems for the future. We have various payers like dental benefit companies and public payers that are already beginning to, sorry, somehow the slides are advancing themselves. Let me get back to the right slide here. Public payers that are thinking about providing incentives based on health outcomes. Certainly the HRSA Health Center program is probably ahead of most of the dental industry in that, and even group practices are beginning to look at those kinds of incentives. I also want to touch a little bit about prevention and behavior science, because we have some things that have certainly changed a lot from the time when I was in dental school. I titled this slide "The Declining Role for the Dental Drill." And what it's referencing is the fact that we have things to be able to, what we call remineralize teeth, arrest caries, seal caries. All this stuff means that these brown spots that you see on these teeth up here, when I was in dental school, there was nothing a dentist could do except reach for a dental drill and drill those things out and put in a conventional filling. Now there's lots of things that can be done, and I'll show you in a little bit more detail a few of those in a few minutes. Can be done without a dental drill, without shots, without the need for a dentist and without the need for a dental office, which is really the key thing here that can stop the progression of dental disease even after it's already begun or prevent it from starting. Also, we know a little bit more about how to have people do the most important thing, which is what do you do on a daily basis? I call it mouth healthy habits. What kind of mouth healthy habits do you have? And we know that helping people change their behavior is very difficult, but it actually works better if you have messages delivered by trusted members of the community, multiple people saying the same thing, being able to coach someone to make some kind of small incremental change and then coming back the next day and reinforcing that. And you really can't do any of that kind of stuff in the context of a dental office where most people are not going there at all, and the people who need most of this counseling are not there on any kind of regular basis. So this all leads to the conclusion the dental industry has really got to be doing more to partner with community structures that are in contact with people who need this kind of coaching on a very regular basis if we're going to be able to make any significant change moving forward. So now let's switch to delivery systems. How do we get in contact with all of the people who are not getting dental care and actually need it, but aren't getting into dental offices? And so I'm going to really focus on the issue of teledentistry, using teledentistry to be able to do that. It's something that I've been involved with, and I'll tell you a little bit more in just a moment, for quite a long time now. And you think about teledentistry as coming in several different ways to do it now. There's sort of advice and referral where someone might send a picture to a dentist and get some kind of response. We have a call center approach where there's some companies out there that are, you pay some money, you get in touch with a dentist, typically results in a referral to an office. You've got people doing on-site care, either limited or full service. So I want to spend just a couple minutes talking to you about a full service dental care system so you can kind of get the idea of what's possible now. It's a system that I've developed over 15 years with a lot of other people, call it virtual dental home, meaning that we're producing all the services of what's commonly referred to these days as the health home concept or the medical home. This one applied to dentistry, but in a virtual environment where different people in different places are working together to make a full service system of care. So the way it works is you have this is a picture of a dental hygienist and her assistant that are in a school, residential facility, nursing home, Head Start center, able to collect dental images, including radiographs, photographs, producing a full set of dental images that everything you'd expect to see in a fully populated dental record. They're collecting the images in the community. They're able to upload them to that picture of the cloud as a cloud-based server. The dentist who's not there on site with them is able to review the images and the records in that server and then make a decision about what happens next. And it turns out, I'll give you some more data in just a moment, that most people can actually be kept healthy by the things that are done by the hygiene community team in the community without needing to be referred to a dental office. So what are the things that can be done? Well, this is an example of in a school, in a Head Start center, in a community center, in a nursing home, using portable equipment, no shots, no drilling, a lot of different things. So one thing is with this new medication we have, it's just a drop of a liquid called silver diamine fluoride. You can stop the progression of this decay for really quite a long time, for months at a time, with just one drop of liquid on the decayed part of a tooth. You can also have this tooth, which is a low-income child who normally would get no care at all until she's in school with a toothache and not learning, or ending up in the hospital emergency room, a very expensive consequence. Again, in just a few minutes now, no shots, no drilling. The hygienist can scoop out the soft material inside that tooth and bond a filling in there, and these things can last for years. So we have huge opportunities now to keep people healthy in the community environment without the need for a trip to the dental office. Now, I don't want to get the idea across that dentists aren't involved in this. Dentists are very much involved through the telehealth system and making the diagnosis and the treatment plan. But actually being in the community, that can be done by a hygiene team. So it's a virtual environment, but can keep a lot of people healthy. So we tested this concept in a 6-year demonstration across California in 13 different communities, 50 different sites. And we were clearly able to show we could make this idea of telehealth connected teams work. Different people in different places could work together. And some of the results of that, high-level results from that demonstration were we could reach people who are typically not getting care. We can emphasize prevention, lower costs. The majority of particularly children could be kept healthy on site, about 2/3 of children in that demonstration. And that was before we had the silver diamine fluoride that I just mentioned. And now we're predicting 80% of children could be kept healthy in the community. If you think about that, it's really pretty astounding, isn't it? 80% of children in a school could be kept have good dental health without needing to make that often difficult trip to a dental office for those parents and all the barriers that they face doing that. 80% of those children could be kept healthy in the dental office, getting to them early, lowering all the costs and neglect, huge benefits from doing that. This is a system that integrates the dental offices and the oral health industry in with the community and brings dentists in a virtual way into places that they normally would not be. So we're seeing a lot of increased interest in this idea. The American Dental Association has just adopted a resolution that I'll just read a couple words. It believes that examinations performed using teledentistry can be an effective way to extend the reach of dental professionals. So really accepting the idea now that professionals can have their reach extended by the use of teledentistry mediated systems. We started out doing this in California, and through the demonstration that we did, had some good policy changes, which I'll reference in a few minutes. And now this is really all over the country. I apologize if you're in a state that's actually doing some things or changing some policy about teledentistry, and it's not in one of the colored boxes on here. I just really can't keep up with all the activity because there is so much, which is a good thing. But I think what this is leading us to is the idea of community-engaged oral health systems. So let me just say that again, community-engaged oral health systems. This is the idea that rather than thinking about dental health happening in a dental office, that's sort of the center of the dental health universe, we can now think about community systems as the way oral health happens, with some people being in the community, in schools, Head Start centers, nursing homes, community centers, geriatric facilities, and they're connected to a dental office through the telehealth system. It's all one full service system of care, but it's distributed throughout the community, its actual physical locations, and able to reach a lot more people and keep people healthy and lower the costs of all the consequences of disease. So these are really the golden rings that are part of our future, having measurement and payment systems that provide incentives to doing this kind of thing, delivery systems that get to people who are not getting care in traditional systems, and then using the very best prevention of behavior science. Now, of course, the title of this presentation, and something that we're facing in a big way and increasingly so right now, is the pandemic. You know, it was interesting in the dental industry when the pandemic started, there was lots of things being published, and one of them was this idea that how much risk there is. You know, some of the little circles are not showing on this slide, but the dental workers, the dentists and the hygienists and the dental assistants are way over on the right here. They were considered the highest risk people because in the dental industry, you're in someone's mouth and you're doing all this stuff that sprays things around. But it turns out that the dental industry has actually been able to do a pretty good job of protecting themselves and protecting patients. And so the National Academy of Science has come out with something now where they're looking at what are the important essential services that people should be doing in the pandemic. And dentists, it uses the word dentist, I think it means dental care, really is at the top of the list of things that should happen now, even in the midst of the pandemic, that it's really a very essential service. But it doesn't mean there's not going to be changes in dental care. Here's a poll, this is the one, a poll that 94% of dentists that are polled saying they're looking at long-term changes in the way dental care is delivered because of the pandemic, looking at things like the need for more PPE and more screening of patients, and you can't process patients through an office as quickly as you used to before. So lots of groups are coming out with guidelines about how do you deliver dental care in this environment. The American Dental Association has this return to work guidance, which has a lot of good stuff in it. The Centers for Disease Control has very good recommendations, which they're constantly updating. But one of the things that's interesting about these guidelines is this National Institute for Occupational Safety and Health, the NIOSH, has this chart for how do you use controls for infections or hazards. And almost all of the guidelines are focused on what are considered here to be the least effective controls. That's the use of personal protective equipment, engineering controls, airflow, but not much emphasis on actually eliminating the hazards at all. And that's where teledentistry can have a big impact in the future. So even in this little crude drawing of mine of a dental office where you're having to highly modify some operatories, even beginning to use teledentistry in an office environment where you're checking in with people before they come in, you're doing all the explanations and patient records, all that stuff can have a benefit. We've been doing polling of dentists now and looking at the idea of how many visits could you actually eliminate by preoperative evaluation, presenting treatment plans, guiding oral health care. It turns out it's around 20 to 30% of visits that don't even have to come into the office at all through a good teledentistry system. And shorter visits, people already understand what's going to happen before they come in. You check in on make sure their insurance and their phone number is still the same, explain procedures, another 20 to 30% of shortening visits. And so if you could have 20 to 30% fewer visits and 20 to 30% shorter visits, that's a really big deal. You could have a lot less invasive procedures, a lot less PPE, less crowded appointment books, lower in-office costs, less infection risk, and certainly a lot of patient appreciation for being able to not have to come in for every time they need something. And so we're looking at offices that are beginning to use teledentistry. They're beginning to see the benefit of using teledentistry in the office, can teach them how to connect with people in the community. And then you start to get the idea of a community engaged system so that the office is just one component of that system. You know, one quick example of that is in a rural community where typically dentists don't set up shop because their understanding is that it's just, you're not going to make a living. There aren't enough people around. Well, if that dentist can actually have a dental hygienist who's working in a town 20, 30 miles away and another one over here, and these hygienists are all connected to that dentist using a telehealth system so that a lot of people can be kept healthy in the small town where they live. But when they do need something more complicated, they're actually getting into the dental office. Then you have an actually viable practice that can really thrive in an area like this and reach a lot more people who are not normally getting dental care. So again, our golden rings for where we need to go in the future. But in order to get there, we really need to think about how we're going to get this kind of stuff adopted. And I've listed here on this slide 3 things that we need to work on. And I mean we collectively. So one is awareness. There's a lot of work to do to increase people's awareness that the idea that we've been talking about is even possible. Then we have policy barriers. In most states in our country, you really can't do, at least not all the things that I've talked about, because the policy environment just doesn't allow it. There's restrictions on whether something can be done, either through scope of practice or licensure or other kinds of restrictions. And the way things are paid for are not uniform when you're doing a teledentistry system versus some other way of doing it. And then even if people are aware and it's allowed and it's paid for, there's still a lot of implementation challenges. So for the foreseeable future, there's going to need to be technical assistance and training provided to help people move into this kind of environment. So I've provided for you it's in one of the resources handouts about teledentistry rules. It's sort of a model set of rules that can help your thinking about how to set up rules that will allow this kind of progress and us to do a better job during the pandemic and as it slowly fades away. And I don't have time to go through it, but in there you'll see some things about definitions, some things about rules applying to scope of practice, and some things about rules applying to payment. I'd be happy to talk to anybody individually if you want to have more detail or talk about that stuff any further, but hopefully that's given you some sense now of the big picture of where we are with telehealth and the ability to have dental care grow and reach more people and do a better job of reaching people early, lowering the costs, and really is something that's going to be a benefit to everyone. And so at that point, I will stop now and turn it back to Eric, if Eric hopefully has your sound fixed now, and be able to answer any questions.
Great. Thank you very much, Dr. Glassman. I believe that I am back.
You are. I can hear you.
And excellent. Then I will just thank you again for that presentation, Dr. Glassman, very comprehensive. And also thank you to Kind Wen, who stepped in for me to get us through that little technological hiccup. So we will now move to our first speaker for the state section, Dr. Samuel Zwetschgenbaum. Dr. Zwetschgenbaum serves as the state dental director in the oral health program at the Rhode Island Department of Health and in the state's Medicaid program. Previously serving as faculty at the University of Michigan, Dr. Zwetschgenbaum has provided clinical care in a variety of settings, including community health centers, hospitals, nursing homes, and private practices. So Dr. Zwetschgenbaum, thank you so much for joining us today, and the floor is yours.
Thanks so much, Eric, and it's great to be with everybody today. First, I'd like to talk about what is an oral health program. A lot of people may not be aware that states have oral health programs, often in their departments of health. Rhode Island is unique in that we are actually a state with only one Department of Health. There's no counties or cities, so we have some interesting opportunities. As I share about our oral health program, I'll also talk about some of the changes due to COVID and some of the opportunities that have presented themselves. So we sit in the Rhode Island Department of Health, or what we call RIDO, and our goal is optimum health for all Rhode Islanders and also eliminating disparities in oral health. We focus on prevention through evidence-based approaches, documentation, which means getting data on oral health, and we see where some of the disparities are, and we collaborate with a lot of partners. We have a staff of 5, and we're funded by grants from the CDC and HRSA, and I'll talk about those grants. But I'll also share one of the first things I'll say that COVID has done is many of our staff have been deployed to COVID-related activities. So we have an awesome epidemiologist who does wonderful work with dental data. Well, they found that she was wonderful with COVID data. So we haven't been able to do what we'd like to do during this period. I know you can't read any of this. This is the org chart for the Department of Health. We sit in the Center for Preventive Services. And one of the most exciting things about working at the Department of Health is all of the cross collaborations with other programs. So we sit, there's an asthma program, there's a diabetes and heart disease program, and having relationships like that helps with medical dental integration. And some of our best efforts in approaching children and families are through our efforts with the family visiting program. Through COVID, we have a very strong team approach, which is, again, that all hands on deck approach that everybody's working on COVID. I will say that we've had a chance to develop more relationships, and I'm looking forward to COVID being over so I can work more and more with colleagues on other areas that I've gotten to know these colleagues now through COVID. So just going over our grants, like I said, we have a grant from the CDC, which has 3 components. One is our sealant program. Dental sealants are an evidence-based approach to oral health where a thin plastic coating is placed in the grooves of the back teeth to prevent tooth decay. And we found that being able to do this where children are, where during the day at schools, is a great way to help vulnerable populations that have barriers to access to care. So obviously, due to COVID, we've had to start to think about new strategies because we aren't able to go into the schools the way we had traditionally. Community fluoridation, water fluoridation, fortunately, that's an effort that has not been impacted by COVID. People are still able to get the safe and effective benefit of fluoridation. Surveillance, I'll talk a little bit about that. That's where we have both a school screening program and a basic screening survey. I'll explain the difference in a little bit. Unfortunately, again, these are ways we're assessing schools. Yes, they've been impacted by COVID. We have a HRSA grant that has essentially 3 components. One is teledentistry, and I'm glad you had a chance to hear from Dr. Glassman. We've been able to work with Dr. Glassman and get some of his insight on developing regulations around teledentistry in Rhode Island. And also we're starting to work with a school to do a virtual dental home program. This school has a focus on community-based services. They're in a community where parents may not have access to traditional dental offices. So being able to develop a virtual dental home will have huge benefits for these families. Second, we developed a program with the HRSA grant called the Health Professions Experience. We found that the diversity of our health workforce doesn't represent the diversity of our state. So we're working with a local high school in Woonsocket, Rhode Island, in the northern part of our state, to give students, many of them first-generation families, opportunities to shadow at dental offices, at medical offices, and in a variety of fields. Unfortunately, that has been impacted significantly by COVID because the dental offices are not able to have the students come in. We fortunately took a little shift. We collaborated with Brown University Medical School, and we were able to provide health education experience just to encourage people to consider healthcare. We have another part of our grant is nutrition training for dental hygienists, which I think has been key because this is something that hygienists can help families with, especially with use of teledentistry to discuss the role of diet. Finally, we had another portion of our grant around increasing use of dental services, of oral health services by pregnant women and during early childhood. And that unfortunately was, fortunately it was very successful, but it unfortunately has been impacted by COVID. So let's see, next slide. Our basic screening survey, we do that roughly every 4 years, where we go into schools, we examine children's teeth, and we look at rates of tooth decay and untreated and treated. This survey we had started to do in 2019. We were hoping to finish in 2020. Unfortunately, we had to put a stop to it because of the inability to get into schools to continue to collect data. Our last survey we did in 2015, which showed a disparity in tooth decay based on race and ethnicity. So you can see among untreated decay, 32% of Hispanic and Black non-Hispanic combined had tooth decay compared to 20% white. So that shows us that we still have significant efforts ahead of us. I will share that you see the dental sealants are much closer, and I would attribute much of that success to our CLRI school-based program. So we know school-based programs work. We just have to get back into be able to doing that. The annual school screening is something that's actually in statute, and it says students in kindergarten through 5 and 1 additional grade must have an annual screening. They can opt out by if they have a dentist, but schools arrange with a community dentist. That dentist comes in and they see as many students as they can, and they send a note back to the parents about the student needing dental care. Well, we decided we had to think of an alternative, both because of the difficulty getting into schools and, as we've seen more frequently now, with greater numbers of students having to stay home because of quarantine, we wouldn't be able to get to the majority of students. So we've been working with a dental public health resident at Boston University, and she's helping me to develop a at-home survey that parents can do and actually take a look at the kids' teeth, then send that information back to us. So we had a meeting with all of the school dentists, and they agreed that maybe this was a year to try something else. So then I had a meeting with a council of school nurses. So again, this is the benefit of working at the Department of Health. I know who to call. So I called our liaison with the school nurses, and they all actually felt that this might have tremendous benefit. What we're going to do is we're going to send a survey to parents in English and Spanish and ask, does your child have dental needs? Does your child need a dentist? Then we're going to work with our Medicaid managed care provider to facilitate care. And also, again, if we can do it with the virtual dental home, that'll be beneficial as well. So this might actually create a unique opportunity. Regarding Medicaid, and like Eric said, half of my position is with the Rhode Island Medicaid program. We've been working very closely with our managed care provider to watch what are the issues of families receiving dental care, and what are we hearing from the dentists. What we hear from the dentists is children seem to be, they're observing more tooth decay when the kids are finally coming in because of their increased snacking at home. So that's obviously of a concern, combined with the fact that they're likely not getting the preventive dental care that they need. We've also noticed that a large portion of our care is provided our federally qualified health centers, and I would say they have disproportionately been impacted by COVID because their staff is primarily from the high density communities that they serve, and many of their staff have to be on quarantine. So whereas many of our dental private practices have reached perhaps to a 70% level of their routine capacity, I would say our health center dental clinics are probably 50% or below. And as Dr. Glassman said, we're confident that the practices dental offices are doing are safe. We're seeing that in the data. We just need to encourage people to get the care. We did have an opportunity to also work closely with our managed care provider to allow teledentistry opportunities so that they could reach out, especially early on in March and April when many of the offices were closed, that they could reach out to families, find out what was the urgency of the dental needs, and help coordinate care. Teledentistry is still being used in many of the ways Dr. Glassman shared, and I think it has opportunities in the future. So as I shared, we have, let's see how this works. We have community health centers all over Rhode Island. These are a great source of care for our vulnerable populations. But like I said, they have not been able to meet the capacity that they previously had, primarily due to their staff being impacted. And our data from Medicaid, our Medicaid managed care program for children is called Right Smiles, treating children 0 to 21. Looking at our proportion of children with a dental visit in the past year, and I know you can't see these numbers, but we've shown small but steady increases over the past few years, which is really wonderful and a credit to a lot of case management. But in 2020, which is the state fiscal year 2020, which is the bar to the right, you can see how the numbers have started to go down. So we know that the proportion of children who will end up having a annual preventive visit is dropped probably about 8%. And this data, I will say it's preliminary due to what we call a claims lag. If we take a little more of a microscopic look, more of on a monthly, you can see that in March and April, that's that little dip you see about 2/3 along the way, the numbers of children having dental visits really, really dropped pretty much to 0 because we shifted to emergency only care. That was lifted early May, and we've been encouraging routine care. And you can see how those numbers are starting to go up, but they have not met pre-pandemic levels yet. What are some other efforts? Like I said, we talked about working with practices on using teledentistry, but we're also thinking about some creative strategies. And again, we're fortunate to work with Dr. Glassman on a potential approach to get fluoride varnish. Fluoride varnish is a key preventive strategy for preventing early childhood caries in very young children. Why not get that to the family, perhaps even by mail, and then use teledentistry to guide the parents to place it? So I think this is going to create an opportunity for interesting strategies. But again, I think it's going to require a strong look at policy. And we've been working very closely with the dental community to help answer their questions. At the Department of Health, we have a web page. We do regular Zoom calls with the dentist, and we're also working on efforts around PPE and vaccination. So these are key opportunities. I think these relationships will help strengthen our relationships with our key partners. So thank you very much. It's been great to talk to you, and I look forward to answering questions as well.
Great. Thank you very much, Dr. Zwetschgenbaum. And our last speaker today is Dr. Rhonda Stokely. Dr. Stokely is the Public Health Dental Director at the Texas Department of State Health Services. She directs public health initiatives to improve the oral health of Texans, focusing on maternal and child oral health and oral health surveillance. She also serves as an oral health subject matter expert for the agency. I will now hand it over to you, Dr. Stokely.
Great, thanks, Eric. And hi, everybody. It's a pleasure to be here with you today. Again, I am the Public Health Dental Director for the state of Texas. And in Texas, we have a separate dental director for Medicaid. So I'll be speaking with you just a little bit about Medicaid, but that is not my area of expertise. The Department of State Health Services is Texas's public health agency. We are devoted entirely to public health. And our mission is to improve the health, safety, and well-being of Texans through good stewardship of public resources and a focus on core public health functions. The Oral Health Improvement Program, which is the program I oversee, is within the Community Health Improvement Division at our agency. We are funded by the Title V Maternal and Child Health Services Block Grant, and our priority populations, therefore, are women and children. We have a staff of 6 in our central office here in Austin, and we have 10 more staff in regional offices. Our main activities are Smiles in Schools, which is what I'll be talking to you most about today. It's our school-based program for Head Starts and elementary schools. We also have Smiles for Moms and Babies, which provides education and resources to promote prenatal and infant oral health. And I'm happy to say that program has not been impacted too greatly by COVID because we work a lot with home visitors. And although they are not visiting their clients in homes right now, they are still having those routine visits virtually. And so still able to talk with oral health about oral health with their at-risk clients. The other main part of our program is Oral Health by the Numbers, which is our surveillance component of our program. We collect data from Smiles in Schools and analyze that data and disseminate it to our stakeholders. And we also look at oral health questions that are in other types of statewide surveys. Some additional activities that we focus on in our program are promoting the HPV vaccine for human papillomavirus to prevent head and neck cancer. We also support the oral health workforce grant activities that are being conducted by our Texas dental schools. And also we support our DSHS Texas fluoridation program, which works with community water fluoridation. And that is continuing on as well. So Smiles in Schools, again, is in elementary schools and Head Starts. We look for at-risk schools, either because the majority of the students are low income or perhaps they're in a particularly rural area with limited access to dental care. This photo here is what one of our setups may look like. Our dental teams bring with them portable dental equipment, and they set up in whatever space is available. Sometimes it's a gym, sometimes it's a cafeteria or a classroom. And they conduct screenings, which is like an exam, but not as comprehensive. We don't take x-rays, but we do get a good thorough look in the child's mouth to see the condition of their oral health. The teams also apply fluoride varnish, place dental sealants, provide oral health education, and also give out oral care kits. Those kits include toothpaste, toothbrush, and dental floss. Typically, our teams screen about 10,000 to 11,000 students per year. And this work is conducted by 5 regional dental teams that are located across the state. And each team has a dentist and a dental hygienist. So things were going along really well. It was a great year early on in the 2019-2020 school year, and then everything ceased in schools because of COVID-19. And a lot of our regional dental teams were deployed to work on the state's COVID-19 response in a number of different ways. Our epidemiologist we worked with was called up to COVID-19 work. Some other staff were called to assist them. We had staff members that were involved in contact tracing or managing teams of contact tracers, and one even became the public safety officer for their building so that the usual public safety officer could do other COVID-related work. So kind of a full range of different activities that our dental program has been involved in related to COVID-19. So for this school year, we have suspended our activities in schools and Head Starts for the foreseeable future. And our regional dental teams are continuing on with their COVID-19 work. And they're also conducting virtual oral health education via a webinar style format and distributing oral care kits to students. This illustrates the first quarter data for our program over the past 4 years. Typically, in the first quarter of a school year, we see somewhere between 4,500 to 5,500 or more students. That's kind of our most active quarter. And here we are, you can see just the significant dip, almost to zero for the first quarter of this year. The impact of this is that, you know, you worry about what's not being caught in a child early. You know, these children may eventually get to dental care, but by the time something hurts and they're telling their parents that something hurts, or the teacher can tell something doesn't feel right with this child, usually it's pretty bad. It's the early evaluations or the routine checkups with the dental office that are the most beneficial to children. We certainly don't want to wait till a child is complaining about pain. It affects their health and well-being, and it affects their ability to perform well in school. March 22nd, there was an executive order issued requiring all dental care in Texas not deemed medically necessary to be postponed. And there were similar executive orders through most states, if not all, around this same period of time. That order was lifted on May 1st, and dental practices were allowed to reopen. This chart here on the right, this graph, is preliminary data from the Centers for Medicare and Medicaid Services. And that little teal green colored line is Texas. Texas had one of the highest dental service rates in May after practices, or after states began to allow practices to reopen. And I've spoken with our Medicaid dental director, and she says that things are, you know, pretty well back to normal, but at about 80%. So certainly not where we would like it to be. And that the DMOs are really working hard to reach out and get people to come back to the dentist to reassure them that it's safe and that it's something important and that they should be doing. The American Dental Association's Health Policy Institute has been following dentists through this entire time, asking them different questions about their practice and how their staffing and PPE concerns, personal protective equipment. And here in the week of November 2nd, they asked dentists across the country what their practice status is. And for Texas, during the week of November 2nd, 66% of dentists who responded said that they were open, but seeing a lower patient volume than usual. And this can be for a number of different reasons. There's hesitancy by some to go to the dentist. We know that from also other data that the Health Policy Institute has collected. There's concerns about whether it's safe or not. Also with dental practices, there's more time now between patients. Everything is spread out more to allow more time for infection control procedures. And so that allows for less volume in a typical workday. When dentists were asked, how does this week compare to what's typical in your practice in terms of patient volume, half of the respondents in Texas were within the 76 to 95% range. Again, close to normal, but not quite. I will skip over this slide about teledentistry since it's been explained so well already. But I'll say here in Texas that during this time, teledentistry has not been an option here because we do not have a law permitting teledentistry in Texas at this time. So therefore, our Texas State Board of Dental Examiners cannot make rules regarding teledentistry. If that should change, one sticking point in the rules that would have to be looked at as to how to change is that the Texas Administrative Code requires documentation of the findings of a tactile and visual examination. And this is expected to be done by the dentist. So for there to be a change, there's either got to be a change that tactile component is no longer required, or that the tactile component can be conducted by someone else. So a lot of logistical things to work through if that is to change. In our previous legislative session, there was a bill that was introduced regarding teledentistry, and that did not pass. Our next session, the 87th, will commence in January. And it is my understanding that the Texas Dental Association and possibly some other groups as well will be introducing some legislation to incorporate teledentistry into statute. So that may or may not be on the horizon for Texas, but it's certainly something that I believe is going to be discussed again this session. So that's just kind of a brief overview of what we're doing. One thing that I did not mention in a slide is that we have convened our school-based oral health programs. There's other programs in the state that maybe operate in a regional or local area. And so we've convened and talked about the challenges we would be facing this year with PPE and logistics and safety measures. And we'll be convening that group again in December or January. It's a nice opportunity to kind of, see ideas, share, and see that we're kind of all in the same boat with these COVID-19 related challenges. And so that sums everything up for me. I'll be happy to take any questions that you have. And I appreciate the opportunity today and the interest in hearing about oral health. So thank you very much.
Great. Thank you very much, Dr. Stokely. Appreciate that presentation. And I'm going to move us right into Q&A right now. So we do have questions that have already been submitted during the presentations, but don't forget, if you have a question, please type it into the audience chat box on your left. And I think I'll start. We have a question here for Dr. Glassman. You covered a lot of great information. I was wondering if you could go into some more detail about the barriers to implementation of a community-focused oral health system, even after questions around workforce and payment are answered.
I'm sure, happy to do that. So that's really the implementation issue. You got the right policy environment, everybody thinks it's a good idea, just actually getting it done. So some of the things we're talking about as the kind of things people need support is, number one, making arrangements with community structures. It's just not that easy to knock on the doors of a school and to be able to go through all the steps of creating a memorandum of understanding or some kind of legal agreement. Sometimes those have to be done by the school board. Most dentists and dental offices don't have any training. It's not their background. It's not what they do. So they need help in making arrangements. There's help that people need in thinking through workflows. So this can work really optimally, but it requires a good connection between what you're doing in the dental office and what's happening in the school, and how do you create workflows so that those things mesh together. So there's some training and thinking about creating workflows. And then there's all the stuff about technology. How do you deploy the technology? How do you use it? How do you test it, make sure that it works? How do you integrate records taken in the community and with the records in the office? So there's just a number of, that's sort of the highlights. There's more, but I think maybe that's sort of a highlight answer for the moment of things that are just natural. They're not natural stuff. They're not dentists, things that dental offices are trained to do that they need help with in order to realize the potential that we're talking about here.
Great. Thank you, Dr. Glassman. Thanks for that explanation and just fleshing it out a little more. I think that's helpful. We have another question here, and I think it could apply to all three of our speakers, so I'll let you all take a crack at it if you'd like. And it's, are there considerations for rural states or communities for some of the options mentioned related to teledentistry, school-based health centers, infection control, et cetera?
I'll let Rhonda take that, because you probably have more rural areas than we do.
Yeah, go ahead, Rhonda, and I have some thoughts after that too.
Well, and I want to make sure that I understand the question. Are there specific considerations for rural areas?
That's right. Yes. Yes.
Well, so one particular concern in rural areas, if we're looking at teledentistry as an option, is going to be high-speed internet. Which is a big challenge in a lot of areas. You know, we might someday have teledentistry, but if people in the rural areas don't have these connections to be able to have that conference call, or for if, you know, the dental staff have gone and set up, if we don't have that capacity, that could be a challenge. I liked in Dr. Glassman's presentation the idea of having kind of a hub and spokes, if you will, of rural care. I thought that looked like a very promising idea to incorporate a lot of different rural areas rather than trying to set up practices in any individual location.
I mean, I can throw in a few other things that I agree with Ron. I think you hit it on the nail. The bandwidth is an issue. So people, in order to use a technology-mediated system, you have to have the technology availability, and bandwidth is one that sometimes is more of a challenge in rural areas, although it's getting better, but still can be a challenge. The other hub and spoke model is something that people need to think about. They haven't been used to working that way. So again, training and technical assistance. And I'll just give you one specific example, which is in the question was mentioned school-based health centers. Think about a school-based health center. Most of these are pretty small things. There's 1 or 2 dental chairs. Typically, they are staffed by a dentist, and that dentist, often they're in like a junior high school or even a high school, and that dentist is doing a lot of things that could be done by allied personnel like a dentist. They're collecting records, they're taking x-rays, they're doing preventive procedures. But think about using that school-based health center in a different way, where that chair with that dentist becomes the place where you do the complicated things. And same hub and spoke that the diagram applied to a rural area could also apply to a school district. Use that school-based health center where the dentist is. You have dental hygienists that are in all the feeder schools, like the elementary schools. They're collecting the records that the dentist can review. They're doing the prevention procedures and the earlier intervention procedures. And then you save those sort of precious resources, those fully equipped dental chairs with a dentist, for the fillings and the more complicated stuff that has to be done by the dentist. Then you're taking that school-based health center, which is often very constricted in its capacity, and you're reaching a lot more people by thinking about it, again, like a hub and spoke system rather than the way it's traditionally used.
Great, thank you both for those answers and digging into a little bit more detail. And we're coming up on time, so there's just one short, I believe it's a yes or no question. I'll just throw it out. And to everyone else who asked questions, we will make sure that we follow up with you after the webinar. But just a question to pose to our speakers: have all 3rd grade statewide surveillance projects stopped due to the pandemic? If you don't have the answer, that's fine, and we can look into it a little more offline.
In Texas, we were very fortunate. We conduct ours every 5 years for kindergarten and for 3rd grade, and both of those were completed before this past school year. So we're current in the way we operate. So we're very thankful for that.
We had to stop right in the middle of our survey, and we were told, don't try to continue now, try to continue next year. So, and we were told, don't use the data that we have now because there are likely some biases based on which schools got their screenings done.
Okay. Okay, great. Thank you both for covering that. All right. So I'm going to stop the Q&A right there. We will make sure that we reach out to anyone offline who asked a question that we did not get to. I just want to thank you all for your questions and participation today. Thank you. So we're on to the resources slide here. We have some resources that you can explore at your own leisure. And this is also, I mentioned at the top of the webinar, this is the first webinar in the NCSL Public Health webinar series. We have a total of 9 webinars lined up over the course of the next few weeks on a variety of topics. They include maternal mortality, suicide prevention, the distribution and allocation of the COVID-19 vaccine, and more. So for a complete schedule and registration details, please follow the link on the slide. Here is my contact information. We would like to extend a final thank you to our presenters. We greatly appreciate the expertise each of you were able to provide today. And I would again like to thank the DentaQuest Partnership for Oral Health Advancement for the support of this webinar. Thank you all and have a wonderful day.